A couple weeks ago, I attended a symposium at the Etihad Stadium on advancements in sports injury management. And I found it really insightful, to be honest. So I thought, why don't I, as a new grad physiotherapist, make a video about the top three things that I learned, two things that I'll be hoping to implement in my practice, and one thing that I'll be hoping to get better at. For the people new here, hello, my name is Dion, and I'm a physiotherapist currently living in Manchester, England. I'm going to try and keep this video under 5 minutes, so I'm going to start a timer now, and let's begin. To fully expose my bias, my whole journey to rehabilitation was inspired by my own knee surgery. So naturally, and number one is advancements in knee surgeries. So traditionally for ACL reconstruction, the bone patella tendon and hamstring autografts are favored by surgeons. However, using the quadricep tendon as an autograft is becoming increasingly prevalent these days. From the research that I've read in the past, it might be more favorable for athletes looking to return to cutting and pivoting sports because of the known deficits in knee flexor strength exhibited by the hamstring autograft, and also some of the research that shows the influence of donor sites on neuromuscular control and firing patterns. While you might not see the same deficits in knee flexor strength in quadricep tendons, you would on the other hand see deficits in knee extensor strength in comparison to hamstring autografts at 6-month follow-up. But as many of these studies have shown, the differences in knee extensor strength is less pronounced as time goes by. To better improve recovery outcomes following surgery, the consultant also talked about using platelet-rich plasma cells to augment ligamentization of the graft. As a physiotherapist and also as a patient that had to endure that whole rehab journey, I can see how improving the ligamentization of that autograft can help with navigating the rehab space, as it can be otherwise tricky. And I see the theoretical benefits of PRP as well, because it does improve growth factors locally at the site of the ligament. However, the current level of evidence to support PRP in augmenting ligamentization is a little bit limited. But it's definitely something I'll be keeping tabs on as the level of evidence improves and more long-term data is there in the field. The second thing that I learned is that the Achilles complex is complex. I love anatomy, and I feel like it's one of those things that you can always learn something new about. One of the consultants spoke about how a GB athlete at the Paris Olympics sustained an injury to her fascia crura. And I was like,
what's that, brother?
So since the symposium, I've spent a little bit of time learning what the fascia crura is. And it's made me think about the fact that there could be a lot of differential diagnoses for a patient that presents with pain in the Achilles region. We know the Achilles tendon is a thick, fibrous band of connective tissue that attaches the gastrocs and soleus muscles of the calf to the calcaneus. Now, the fascia crura is also dense, fibrous connective tissue that blends into the end of the Achilles and is part of the deep fascia of the leg. To add a little bit more spice to this equation, the fascia crura forms a confluence with the paratendon, which is loose vascular connective tissue that is a sheath-like structure that surrounds the Achilles tendon. For me, understanding the differences in structure, organization, and function of these three is really important because it has a lot of implications to how I would design a rehab program. The Achilles tendon requires more structured loading, versus the fascia crura would require a little bit more of a full systems approach to restore dynamic stability and monitor movement quality. But the paratendon would need longer rest and anti-inflammatory focus. It's not to say that if a person has pain, it might just present as one or the other. It can be a combination of the three, but it's just good to keep in mind that it could just be a little bit more than just the Achilles tendon. And the third thing I learned is that rugby athletes are different. Almost every single consultant had a story to tell about how a professional rugby athlete and how they defied the odds of their injury and managed to return to play. The one that stood out the most to me was a rugby player that had cervical myelopathy and was experiencing shocks and burning sensations in both of his hands. He obviously wanted to return to play and didn't want to retire, so the surgeon conducted a 2-level anterior cervical discectomy and fusion. Now, if that was me, I would retire right after that surgery was completed, and I'd maybe do a little bit of coaching, start a YouTube channel. But that athlete managed to return to play after many months of rehabilitation and a lot of support from a massive multidisciplinary team. For me, it goes to show that with the right team in place, anything is possible.
Anything's possible!
Alright, next we'll be moving on to two things that I'll be hoping to implement in my practice. So the first thing for me is to remind myself to think more holistically about my patients' conditions as a practitioner. One of the talks that were delivered was on lifestyle and metabolic health. The consultant gave an example of the impact of chronic low-grade inflammation on osteoarthritic joints, and how a simple modification to your diet, such as implementing more of a Mediterranean diet that's known to have anti-inflammatory benefits, can help with decreasing pain and also improving functional outcomes. We know how important these things are, but sometimes it's not at the forefront of my mind when I'm in an appointment. A resource that was mentioned in the symposium and that I found useful in the past as well is called Moving Medicine. It's basically a website for clinicians to help them navigate those sensitive conversations around various conditions such as obesity, diabetes, COPD, and I'll add the link to the website in the description below as well. The second for me is to use more analogies with my patients. So I've learned about the TFCC in the wrist a bunch of times and I've memorized this function as well. But one of the consultants compared the TFCC to a drum skin to basically explain that the more taut the TFCC is, the better it works. Because of my love for music, as soon as he said that, it just clicked for me and I feel like it's going to stick with me forever. And lastly, to finish this video, one thing I'm hoping to get better at is interpreting medical images. During the symposium, there were a couple talks on stress fractures and apophyseal injuries as well. And for these presentations, the consultants would have pictures of MRIs and ultrasound. I feel like a lot of other people were a little bit better at spotting what the consultant was talking about, and I wasn't nearly as good. Physiotherapists aren't diagnosticians, but as you can tell by this video, I am deeply passionate about MSK. And just getting better to interpret X-rays, MRIs, and different types of images would be, I feel, more beneficial for my clinical outcomes. And I'd also be able to educate my patients a little bit better about what's going on with them. So that's something I'll definitely be hoping to improve on, whether it's with CPDs or a proper course, because I do know it's something that I just need to expose myself to a little bit more repetition to get more comfortable with seeing what I'm supposed to. So that's it. I hope you enjoyed my main takeaways from the Manchester Symposium and I managed to stay within my 5-minute window.
Ooh, yeah.
If you found this useful, please like and subscribe to my YouTube channel, as I'll be using it to post weekly videos on things that currently influence my practice that I've done in the past, or just like this, what I'm up to now as a physiotherapist living in Manchester.